Good afternoon and welcome to this month's Northern Virginia Health Policy Forum. I'm Jim Scott, President and CEO of Applied Policy, a health policy reimbursement and consulting firm in Alexandria, Virginia. This month, we have seen almost daily policy announcements and action on senior appointments that certainly will impact the quality and availability of healthcare for Americans. As we meet today, Robert F. Kennedy Jr.'s nomination to Secretary of Health and Human Services has cleared the critical Senate Finance Committee and is expected to head to the full Senate next week. Today, the forum welcomes three reporters who have been delivering in-depth coverage of the Trump administration's rollout of its healthcare policies and their potential influence on federal agencies and on Capitol Hill. Joining us to help identify the most important bellwether events from the past few weeks are Maya Goldman, healthcare reporter for Axios, John Wilkerson, Washington correspondent covering the politics of healthcare for STAT, and Phil Gallowitz, senior correspondent for KFF Health News, reporting on the intersection of health policy, health economics, public health, and consumer health. Welcome to you all, and thank you for taking the time out of your busy schedules to join us at the forum. I'd like to start by asking each of you what brought you to your current positions. We have a lot of young people aspiring in our audience, and they would like to know about how you got to where you are today. So, John, what professional experiences led you to your role at Stat News?
Well, first I got a PhD in molecular biology. No, just kidding. Um, I started off, I kind of backed into it. I started off by working more than 2 decades at a newsletter called Inside Washington Publishers. I was covering healthcare that whole time, FDA, CMS, drug pricing, and then I eventually moved over to Stat. So healthcare is now my beat. I know too much about it to write about anything else.
Maya, what professional journey brought you to Axios?
Well, thanks for having us. I knew that I wanted to be a reporter when I was graduating school and didn't know what I wanted to report on necessarily. Didn't really have like a specific beat in mind, but I was looking for jobs and there was an opening at Inside Washington Publishers on the Inside Health Policy newsletter with John, and that was my first job out of school, and I quickly became kind of obsessed with health policy and found that I really loved it, and so went from Inside Health Policy, Inside Washington Publishers to Modern Healthcare, where I reported on rules and regulations, and then went over to Axios to help start their health policy newsletter, and now I cover national healthcare.
Phil, what about you at KFF?
Sure. I started out as a hospital administration major at Penn State, and while at school, I joined the school newspaper, so I got the journalism bug there. And when I graduated, I had sort of the option to go into healthcare, go into journalism. I chose to take a job at a newspaper in Harrisburg, and within a year or two, I was covering healthcare full time in Harrisburg, and really liked it. And the beauty of healthcare is, it's all types of beats. It's a consumer beat, it's a business beat, it's a public health beat. It's everything that you want to do, you can do within healthcare. And so I had experiences working in Harrisburg for a number of years. Then I went south to Palm Beach, working at Palm Beach Post for a number of years. Then worked for the Associated Press as a national writer in New York, covering the drug industry and the hospital industry. Went back to Palm Beach, and then a few years later, KFF started KFF Health News in 2009, and I was fortunate to be one of the original reporters that they hired. Interestingly, they hired 4 journalists back in '09, and we're still there in 2025. So that's how my journey got to KFF.
So, Phil, let's stay with you. Can you give us a top line look at the issues you're most closely tracking?
Sure. A lot of it is Medicaid, Medicaid, Medicaid. We've seen huge growth in Medicaid during the pandemic. Then we had an unwinding where people needed to renew their eligibility. So we've had some drop off of about 10, 12 million people off Medicaid. And now there's a concern. The Republicans have said when they took power, they were going to look to shrink government and shrink Medicaid. And we're waiting to hear exactly how they're going to do it. There's thoughts that they're going to eliminate the funding for the Medicaid expansion that added over 20 million people to Medicaid. There's thoughts that they're going to cut the general funding that goes to states and sort of the match rate between the federal government and states. And there's also thoughts about changing the funding outright from being an open-ended grant program to states to a per capita cap where the money's capped each year. So that's the thought, but right now we're still on hold in terms of waiting for that bill to drop or waiting for that announcement. The president the other week said that he was going to love and cherish Medicaid, and all that he would do was address fraud and abuse within Medicaid. We're going to wait and see if that's the case.
Thanks, Phil. Maya, what issues are you following?
I am also, like Phil, very interested in Medicaid and Medicare, and health insurance policy in general. It's, a lot of the money in the healthcare system is flowing through the payers. And so there's a lot, they have a lot of influence over how healthcare in the country looks. So I spend a lot of time there. One part of my beat that's a little newer for me, but definitely growing and very important, is public health, and like the way that CDC and FDA and NIH are impacting the country as well, and the health of the country. And we've seen this week a lot of discussion about that data and how important that is and how we follow that and what happens if we don't have access to that. So that's definitely top of mind. I also am very interested in the healthcare workforce and how payers and providers and patients and pharmaceutical companies, 4 Ps there, I think, all interact with each other, and how things like technology are changing that.
Thanks, Maya. And John, what's top of mind for you?
I echo everything everybody just said. Obviously, Medicaid is huge. The one thing that didn't get mentioned explicitly is the enhanced ACA premium subsidies. I think that will also be something to watch, though that one's a little bit different. On that one, they have to, the subsidies are expiring. Most of the audience probably realizes this, but so the dynamic is a little bit different. In order to do anything on that, Republicans just need to not do anything as opposed to do something. So they could cut those premium subsidies just by letting them expire. In addition to that, Maya also mentioned that there are these executive orders out. One reported in the Wall Street Journal and BioCentury that supposedly is coming. We're trying to figure out how legit that is, but that would fire a lot of people, thousands apparently, at FDA, NIH, CDC. So that's a big deal. Obviously, what Elon Musk has been doing, getting into the Treasury and Medicare. We don't know exactly what's going on there. And that one is interesting because I think reporters everywhere are trying to balance whether they should freak out about this or whether it's not a big deal. And there has not been really much any transparency at all on that. And so I think we're trying to figure out, do we care about that? Is it a big deal or not? And so you're asking me, like, what are we monitoring? What are the big things? I don't know if that's a big thing or not. It seems like a big thing, but we're waiting to see.
Great, thanks. The Trump administration has already indicated elements of their healthcare priorities through executive orders and agency nominations. What do we already know about where we're headed in healthcare, and what would we look for in the next round of White House actions? John, you get to go first this time.
Oh, dang. Next round of White House actions. I'm not sure. I think we're waiting to see what RF Kennedy Jr. or RFK Jr. Ends up doing. He was pretty vague on what he intends to do to make America healthy again. And he's said so many controversial things in the past that I think during his confirmation hearings, it was all focused on what he has said and whether he meant what he said. And so we didn't get around to, the senators didn't get around much to talking about what he has in store for HHS. And when he was asked by Dr. Senator Cassidy, what his plans are for instance, Medicare, Medicaid, he seemed to confuse them. He didn't seem to confuse them. He did confuse them. I don't know that even they know in this space yet what they plan to do.
Phil, anything to add there?
Yeah, I guess the question is, obviously RFK was selected, and he's, sort of a flashpoint, and sort of Dr. Oz as well to be the CMS administrator. These people are well known. Whether or not these are going to be the two people who really drive healthcare policy, I think that's unsure. I mean, usually you think of the head of HHS and CMS as the ones who are driving policy. I'm a little skeptical of that, and I think it's going to be other people who Trump has hired to be his advisors in the White House will have more say and control over driving, particularly Medicare and Medicaid policy, than these gentlemen, because they just don't have a whole lot of history there, and you think they're going to have a lot to learn in the first several months. They're not. I mean, not too many people are used to running, an $800 billion program, of course, but these people have not worked in major government institutions, so they'll be certainly many months of getting up to speed, you would think. And as John said, it's RFK was sort of very vague. We heard a lot of senators ask him stuff that he would not do, not touch agriculture policy, for instance, because RFK has also talked about, changing what we eat and how diet is important. There's no debate. I don't think he didn't get any argument from Democrats on that, but whether or not he's going to change sort of agriculture subsidies that might have some impact on what foods people get to choose or what the price of food is, it's unclear. And obviously, the head of HHS does not oversee the USDA. So that's that. And then obviously Dr. Oz, when he ran for Senate a couple of years ago, he talked about being a big fan of Medicare Advantage. There's been some talk about having, instead of people being in traditional Medicare and choosing Medicare Advantage, where right now we have about 51% of people in Medicare Advantage and 49% in fee-for-service. There's some talk to make Medicare Advantage the default, that you would automatically start out in that program unless you opt out. Again, that would be a huge change after all these decades of having Medicare Advantage as a choice. So we'll wait and see on that.
And Maya, anything to add there?
Yeah, I co-sign everything that Phil and John have said. And I think also it's important to think about some of the things that have already happened, that we do know already, like pulling back on health equity initiatives. That's been, a concrete thing that has started to happen through President Trump's executive orders. And that was a big priority of the Biden administration, to make healthcare more accessible to and equitable. So there's a lot of stuff a lot of programs and dollars that could be untangled there. Deregulation is a big priority of the Trump administration. He put out an executive order last week, I think, that says for every new regulation agencies propose, they have to identify 10, I think it was, that that can be taken away. And healthcare is one of the most regulated industries in the country, as I'm sure everybody on this call knows too well, maybe. And so that could have huge impacts. We don't really know exactly what that looks like in practice yet, but definitely watching that closely. And then basically like squashing our global health work through gutting USAID, pulling out of the World Health Organization, and all of that. So I think, those are some concrete things that we already know, but I think it's also important to state that, like, when you look at the big picture of things, of all the information that's coming out from the executive branch so far, healthcare does not seem to be at the top of the agenda, or really anywhere near the top of the agenda, at least in my opinion.
Thanks, Maya. And let's stay with you for just a minute. Within with a new Congress, a new administration, and new agency leadership, what does your reporting tell you about the most important trends to watch in terms of healthcare policy in Washington?
Yeah, I was saying this just before the call. I think what comes to mind right now is something that I would not have thought of, even 2 weeks ago. But right now I'm most closely watching how data flows in and out of the federal health agencies, and what information the government is allowed to collect and allowed to put out, and the like veracity of that data. And I think that that's just sort of like, something that's very new and uncharted territory for me, at least. But I am also, very interested in how the Make America Healthy Again movement changes health policy, if it, does make a meaningful dent in things. And as Phil said, Medicare Advantage and Medicaid cuts that could be coming, changes to Medicare Advantage and Medicaid cuts that could be coming.
John, anything to add there?
Yeah, I mean, to some extent, at this point, and thanks for mentioning DEI, Maya. That's a huge thing that I left out. Sorry, just gonna reject that call. So the theme seems to be, with MAHA, the themes are, they want to make food healthy. They want to get rid of corporate influence. What are some others? They want to focus on chronic disease. They want to avoid chronic disease. And I think that that's a big piece of this that some people might not be grasping yet. I think that an effort to avoid, like by focusing, even though we don't know how they plan to avoid chronic disease yet, I think that by focusing on that, it kind of gives them an excuse to when people lose their healthcare coverage, whether it be from Medicaid or from the ACA plans, and that's the theme that I'm the biggest thing that I'm watching for, is how the Make America Healthy Again movement ends up affecting health insurance coverage.
Thanks, John. And then Phil, trends to watch?
Well, I think just to piggyback on what John said, I think the administration is going to try to change healthcare. Their effort is to do it outside of insurance to a degree. Part of their philosophy is a lot of things go into affecting people's health beyond if they're just insured. Yes, there's been a lot of data and studies show when you have insurance, it increases your access to care and increases your access to preventative care, and that's a good thing. But there's also a lot behaviors every day are big things. So I see the administration in some ways trying to make some inroads there. And that's a tough road to hoe, because changing behavior is much easier said than done. And yeah, and then what their policies will be, it's uncertain. Obviously, there was a lot of attention toward vaccines during the RFK confirmation hearing, and there were assurances that were given that that RFK would not change vaccine policy. But I think we can look to RFK to probably put together a panel to look at vaccines, and he will do that. And what comes from that and who sits on that panel will be real interesting to watch. And then it'll be real interesting to watch what efforts, if any, there are to promote vaccines in this country. We heard everything during the RFK about that he'll keep his hands off vaccines, but as we know in this country, we're falling behind when it comes to providing vaccines, particularly to children and adults as well.
So, Phil, we had to reschedule this webinar because it fell on the day when RFK's Jr.'s Senate hearing was happening last week. So now that he's moved closer to being Secretary of HHS, if you had to guess, what do you think the first actual policy he works on when he becomes Secretary of Health and Human Service would be?
Hard to say, but obviously he's made a big push with food additives over the years, and that's somewhat of a relatively easy one, though the food industry has a big lobby in Washington, as we know, and keeping the price of foods down and making foods more amenable to people. And so any kind of change is difficult. But to a degree, though, the manufacturers have also tried to move away from food dyes as well over the last few years. So, and one of the last things the Biden administration did before they walked out the door was to eliminate red dye number 3, which the FDA declared a carcinogen almost 38 years ago, and they took that action. So I think that may be one area that he may want to walk into is food additives and try to make some announcement. And again, that would be him working in conjunction with the FDA. That's the real specific area that he could have some influence in.
Thanks. Maya, what do you think the first thing RFK Jr. is going to do when he gets to be secretary?
I think Phil was spot on with that. I think, it's really hard to know exactly what is going to happen. I think John mentioned RFK Jr. has a clear policy direction that he wants to head, but not very many specifics that have been released at all. And his agenda, right, it like mixes some very mainstream bipartisan ideas that are easy to get behind, easy to rally people behind, and some things that are veering on conspiracy theory. And so I think it will just, kind of be a waiting game to see and figure out, where things go. I think there have already been some key people hired underneath the secretary's office at HHS, but I'm very curious to see who he brings in as his advisors as well, because I think that will tell us a lot.
Thanks. And John, what's your bet for his first substantive policy priority when he gets to be secretary?
I don't know. Sorry, that doesn't sound like a very smart answer, but I think that he has been extremely light on details, and I'm so curious. I was invited after his first hearing before the Finance Committee to go over to the Heritage Foundation a few blocks away, where some of the heads of the MAHA movement were hosting reporters. And we tried, they're not part of the administration, so they're not, they didn't want to speak for the administration. I get that, but we were trying to, on several occasions, we asked them, like, what are the policy levers for achieving your goals? Do you get rid of FDA industry user fees? Do you, how do you just, give people HSAs that cover healthy meals? I don't know. So it's, I'm waiting to see, but I think Maya's right. Personnel is policy. So we'll have a better idea, I think, once they start bringing people in, which direction, or, like maybe what specific things they want to work on, because we know directionally what they want to do, which is to end chronic disease and to, I guess, get more information on vaccines.
Thanks, John. And so you've written that MAHA is top of mind in Washington, and we've heard you talk a little bit about it so far. I'm not sure everybody is as familiar as you are with the MAHA movement. So it's my understanding that MAHA is not necessarily RFK's own thing. It's more of a broad movement that he's a representative of. Can you tell us a little bit of background on what MAHA is, so we can tell where it might be going?
Yeah, I guess that one's kind of difficult to answer too. I mean, we have like some influencers out there who have been a big part of MAHA. Mostly they've been concerned with too much corporate influence over drugs. They feel that we're making people sick, that that everybody in the system, whether it's drug makers or doctors, are part of the problem, that they're trying to get people, they're just trying to make money, that this is them talking here, that they're doing what they can to get people to go to to medicate people, because that's an easy solution, instead of trying to avoid having to medicate people in the first place. And having more doctor office visits. I know some of them have mentioned the AMA's RUC. I forget what RUC stands for. Relative. Anyway, it's the one that sets the billing codes for what doctors are paid, or it doesn't set them. It advises Medicare. They often get adopted, not always. So they have a problem with that. So who's the MAHA movement? It's, again, I don't have a great idea of who it is. You have some key figures such as Del Bigtree. He's been a huge vaccine critic. People like Casey Means, who's, I don't even know what to refer to him as. He's been a businessman in the past. Yeah, I'm not answering this question very well, but I think that's the problem that you run into with movements, is that they can be kind of difficult to define exactly.
Great. Thanks, John. Phil, there's been indications that initiatives of the MAHA movement have been implemented for decades and now are being recycled in new packaging. What do you think that means for the potential success of MAHA moving forward, particularly MAHA elements that could be covered by Medicare?
Again, uncertain. Medicare has tried to offer some sort of over the last number of years, it tries sort of non-clinical coverage to things that help affect people's lives, such as helping them make changes in their house, bars so they don't fall in their bathroom, handlebars, things like that. So there's been a push for a number of years that says that people who get coverage need help beyond just coverage for going to the doctor, going for the hospital, going for drugs, but going into things that can affect their health that aren't pure health. But there's also been a push within the Trump administration to say a lot of that's a waste, and a lot of that is hasn't really proven anything, and a lot of that, both in Medicare and to a degree in Medicaid, has let these programs grow dollar-wise without any real proof that they've worked. So there may be sort of cross purposes there, where one part's saying, "Hey, let's grow Medicare to pay for some things that can affect people's health that aren't clinical health," and then other people who sort of say, "No, we have to control the budget." That's, having said that, it's really, again, as John said, it's really unclear. Again, chronic disease is not a new issue. I mean, it's great that people are addressing it, and one of the reasons why chronic disease is an issue is because we've dealt pretty good in this country with infectious disease and things that would rob people and of life expectancy. We've done a pretty good job addressing those issues over the last number of decades. So people are living longer, with the exception of we had during COVID, life expectancy fell. But people do live longer. The longer you live, you're going to develop some diseases, and for the most part, people are living longer with diabetes and asthma. Cancer, in some cases, is turning into a chronic where people pay attention and have it for years and years. Again, same thing with heart disease. These are chronic diseases that affect a large part of the population. Not new issues. And to say that there hasn't been any attention to them the last many decades, I'm not sure that's really true. We've certainly written a lot about efforts to help people with diabetes to better diagnose these illnesses early on so people can address them before they get too serious. So, yeah, there is a degree of, really what's new. And yes, the numbers of people with these diseases have gone up, but so has the population. And it's a positive thing to be able to diagnose somebody to a degree, to somebody that knows that they have diabetes when they're 45 or 50, so they can address it. And yes, it makes the numbers look high, but it's also they know, as opposed to waiting until they have a heart attack or waiting until they end up in the hospital or nursing home. So there's positive effects that people can know that they do have a chronic disease because they can take steps to address it. But whether there's anything new that this administration is going to do in terms of funding local efforts to help people better address these, that's a wait and see.
Yeah.
Thanks, Phil. Anything to add, Maya?
Yeah, sorry to jump in here. I think Phil and John absolutely hit the nail on the head, or whatever the expression is there. I would just add that I think the really interesting thing for me with the MAHA movement to watch is how the Republican Party's more like traditional conservative budget hawk wing and the more populist wing interact here. And just like whether that does bring up tensions, whether there are places that they can align, whether this ends up being something that mostly happens outside of the federal government, I think is really interesting. And the other thing that I wanted to add is that I think that the MAHA movement is not new, like that there is something that has been here a long time, but it's also like political packaging that really taps into people's fears about healthcare and the health system and children's health, I think. And so think that's like an important thing to realize about it.
Yeah, and if I may just jump in out of turn here real quick, something that I forgot, I just want to make one point, and it's again a thematic point, and that is they're trying in the past when they've tried to tackle a lot of the things that that we just talked about, such as getting people, making sure that people have transportation to get to their doctor, making sure that people have safety measures in their house, such as the bars and so that they don't fall while they're in the bathroom, in the kitchen, or whatever, that kind of thing. I think they've tried to achieve these goals of keeping people out of the hospital and keeping them healthier via insurance. And now it seems like the goal is to avoid the insurance part. And that seems to be thematically what is new about the new approach. Whatever that new approach ends up being is not clear, but it does seem like they're trying to make it so that people only have insurance for like catastrophic stuff, and that otherwise you use your insurance, you pay on your own for more of the day-to-day stuff, and that you avoid the need of having insurance for catastrophic problems by staying healthy. I just don't know how they're going to keep people healthy yet.
Well, thank you all. Maya, the Trump administration announced that it was going to continue the Biden policy of Medicare drug price negotiations. And right before he left office, the Biden administration announced 15 drugs for the new round. When Dr. Oz takes over CMS, if he is confirmed, what will his impact be on the ongoing drug price negotiations?
Yeah, I think that's a really good question and a very open one. I can't recall, maybe John and Phil can jump in here if you guys have anything on this, but I can't recall any statements that Dr. Oz has made on the drug negotiation process. We know the Trump administration has said vaguely that they will continue the process, but there are, and most of the process for negotiating these new prices, lower prices, is pretty descriptive in the statute. So there's not a ton that the new administration can do to change that, but there are levers that they can pull. They can, decide to be more aggressive or less aggressive with the companies with the pharmaceutical companies. And there are a couple other places in the margins that they can do that. So it'll be interesting to see how they go about that. But yeah, I think we don't totally know yet. As far as we know right now, it's moving along as scheduled.
Speaking of the schedule, do you think that the offer of the federal employee buyout that went around the Centers for Medicare and Medicaid Services, as well as the rumored layoffs coming shortly thereafter, could that affect the timeline for the drug price negotiations or have an impact on that?
It could. I think another thing that we don't totally know yet, CMS definitely staffed up a lot in the past couple of years to run that program, the drug negotiation program. There's a lot of work that needs to be done around that. And there are statutory timelines that CMS has to meet for the different parts of the process. But who's really going to enforce those timelines, I think is the big question. And even if patient advocacy groups, if, let's say, hypothetically, the Trump administration misses some of those deadlines because either they decide that they don't want to do this program anymore, or they don't have enough staff to carry out the functions in a timely manner. Even if patient advocacy groups decide to sue, it's not clear from my conversations with them that a judge would say that they have enough standing to sue, because these prices ultimately don't go into effect until 2027. So I think there are just so many questions there that it's really hard to give any answers, which is frustrating, but the reality.
And Phil, any thoughts on how drug price negotiations are going to go under Dr. Oz?
Yeah, well, one of the big drugs, that was just listed in the latest round of drug negotiations is Wegovy, which is, there were 15 listed, but the one that really got people's attention was Wegovy because it's a, high in demand drug and a very expensive drug. I think about $1,000 a month. And it's showing a lot of good signs. It helps a lot of people lose weight, and the Biden administration had wanted both not only to have it in the Medicare negotiations, but to have it covered by Medicare and requires states to cover it. This is, we're trying to control the costs, and there's a whole big debate of should we cover this, pay up front for this drug that can help a lot of people, where the thinking is down the line it will save us from some bigger expenses. There's different people have different opinions on that, and some states are covering it, most states are not in the Medicaid program. So we expect the administration. I would expect that they're going to continue the negotiations. It's in the law. Trump has made a deal that he likes to negotiate. These things take, as Maya was saying, these things take a couple of years to play out. You negotiate this year. It's usually a 2-year ramp-up period until those prices may take effect. But I would expect with Dr. Oz that we're going to continue to see the price negotiations. I'd be really surprised if they don't continue it.
And John, with the obesity epidemic in America being the source of a lot of the chronic diseases Phil mentioned, like diabetes and heart disease, the GLP-1 drugs like Wegovy seem to offer some promise. Have you heard anything from the Make America Healthy Again movement on their views on the use of those drugs to lose weight and avoid diabetes and heart disease?
Yeah, that's an interesting question because there are two countervailing forces here. One is, I think Maha thinks that we're over medicating people and that it's bad that people have problems with, people are diabetic, or that we have an obesity epidemic in this country. And they think that we shouldn't just allow that to continue happening and then rely on some miracle drug to fix it. At the same time, those drugs work. And I think even a lot, I don't know if people in the Maha movement has specifically said nice things about him, but I know Kennedy said some nice things about him. And so I think they do understand that the GLP-1 drugs work really well, that they could do a lot of good, but at the same time, they don't like that we're relying on them in the way that we are, and that they're expensive. As for negotiation, again, we have some countervailing forces there. Trump does fancy himself the master bargainer. That would seem to indicate that he would want to do a really good job of bargaining lower prices. One oddball connection here I'll make with Wegovy, and I don't mean to imply anything with this, but if anybody wants to talk to me, I'd love to talk to you about it. Wegovy is made by Novo Nordisk. Novo Nordisk is a Danish company. Denmark owns Greenland. I don't know what all of that means or how we connect those dots, if there is any connection, but it's an interesting thing to keep in mind, huh?
That is an interesting thought. Let's turn to talk a little bit about Medicaid. So, Phil, since you're the Medicaid expert on the panel, under President Biden, enrollment in Medicaid hit a record high and the uninsured rate hit a record low. Trump's return to the White House, along with the GOP-controlled Senate and House of Representatives, is expected to change that. How soon can we expect those changes, and what do you see coming?
Sure. I mean, again, I think Republicans see insurance and the role of insurance differently than Democrats. I think Democrats see the more people insured, they see this getting people healthy, getting them the treatment they need is a positive thing. That the fact that these programs have grown to cover, at some point, with 1 in 4 Americans, they saw as a positive thing. The Republicans see the fact that these programs have grown as a negative thing, that people are too government dependent. And they've also, number of Republicans don't really believe that having insurance really improves people's health. So there's debate even on that core concept. There's no debate having insurance protects people from going bankrupt. When you go to the hospital and you come home with a $40,000 bill, and insurance is there, there's no doubt it helps you financially, but whether when you have insurance versus not having insurance, a lot of Republicans don't believe that, it doesn't really increase access. They look at Medicaid and say, hey, people often have problems finding specialists or having access to get into primary care in some areas. So there's a sort of inherent debate. But again, I think within Medicaid, a couple areas we're going to see is one is Medicaid work requirements. I think is going to come back again. That was certainly part of Trump's first term, where he allowed he approved a number of states, and one state, Arkansas, put it into play back in 2018. That resulted in about 18,000 people losing their coverage, largely because they failed to meet the monthly reporting requirements of the program. So I think we're going to see some more push again into work requirements, and we're already seeing some states put in some new waivers into this, like Arkansas wants to get back in, Ohio is looking to do it. Georgia has a very small work requirement program that is in existence for a sort of their small Medicaid expansion that they did. That wasn't the full expansion. So I think we'll see more of that. I think they'll be a little different than it was tried before, where you had everybody in Medicaid would have to report in every month. I think states have learned that may not be the smartest idea to try to get people to get back to work. There may be more incentives and more coaching, if you will. So I think that may be, and then you also may see the administration try to change the law, because right now there are court cases that block Medicaid work requirements, and those court cases found that work requirements didn't mesh with the existing Medicaid law, which was about providing coverage. It was not about work. It was about providing coverage. So we may see some effort by Republicans to try to change the Medicaid law and to put in the law that a type of work requirement would be allowed, just so when these things come back to court, these things may get through the court system as opposed to being blocked by the court system. And then outside of work requirements, again, I think we're going to, I think there's going to I think there's going to be some effort to undo the expansion coverage. Right now, the federal government since 2014 gave states a deal where they'll cover 90% of the cost of the expansion populations, people up to 138% of the poverty, and that was almost double in many cases what the traditional federal match was. And we've seen Republicans say this is discriminatory, that why do people on expansion get a higher federal funding than pregnant women or children? And so I think we're going to see some push to reduce that and shift people from Medicaid onto the Affordable Care Act exchanges. And through that, people expect some people are going to fall off and not have coverage. And the Affordable Care Act exchanges are not the same as Medicaid, typically have a lot more co-payments, often have a premium or a deductible, which you don't have in Medicaid. On the flip side, on the ACA marketplace plans, you typically have a little broader networks, broader choice of doctors. So that would be one plus. And yeah, so I think those are the two main areas I think I would look to first.
Thanks, Phil. Staying with you, one of the things that I've heard often, but I don't see being talked about now, is that even under the current Medicaid program, Medicaid is underpaying providers, and providers try to avoid seeing Medicaid patients or take a loss when they do. For example, several states set their Medicaid payment rates at 80% of what Medicare pays, and Medicare feels like it's paying accurately for those services. So 20% less can't be accurate. Have you heard any talk about adjusting the Medicaid payment rates to pay providers fairly?
Well, a lot of that comes down. Payment rates are set at the state level. It's not in Medicaid. It's not the federal government that sets those payment rates. And there's a broad range of what states pay. Most states, as you say, pay less than Medicare, but there's a number of states, particularly out west and in some rural areas, that they pay more than Medicare, particularly for some specialists. Because states, after all, are trying to set their budgets. They have to balance their budget every year, unlike the federal government. So they do that through payment rates. And obviously having these lower payment rates is why it's often hard for people on Medicaid to find providers. And when we've seen Medicaid programs add dental, for instance, a lot of dentists just don't take Medicaid. part of that is due to the low pay. Part of that is a perception that lower income people often miss their appointments, and dentists don't want to deal with a population where they'll have too many no-shows. So, what efforts? I think that's going to come down to states. And again, if states are going to have less money, if they cut back the Medicaid expansion dollars and take those dollars away from states, I'm not sure states are going to be in any better position to increase their payment rates to physicians. States often drop their payment rates when they face difficult economic times. And then sometimes when economic times are good, you expect states to increase those rates, though it's often slower on the upside than it is on the downside.
Last question on Medicaid, and this one comes from our audience. With the new administration, what do you think are the ramifications for child and maternal health?
I can jump in here. I think that's an area that I'm watching very closely, specifically with the rollback of DEI initiatives. I think if we can't say gender if researchers can't use the word gender, what does that mean for the data that already exists, is being collected, is going to be collected in the future that informs these policy changes? And I just don't know the answer to that. There's also like very clear evidence that, Black women experience maternal complications at a higher rate than white women. And can the federal government no longer put money into addressing that? I don't know. With kids, I think we're almost undoubtedly going to see some chilling of vaccination rates, and whether or not there's policy changes. Pediatricians have already said that the statements that are coming out of the administration officials are chilling vaccination rates, and vaccines prevent a lot of very preventable illnesses. So I think that we could see a resurgence of illnesses. At the same time, I think that there is a genuine interest in the new administration in tackling things like children's diets, children's mental health. And so that will be interesting to see if there's any real policy meat on those bones.
Thanks, Maya. And you mentioned the vaccine mandates. Medicare currently covers several vaccines like flu and pneumococcal pneumonia and hepatitis B. Do you think the anti-vaccination feeling would extend to stopping Medicare coverage for those vaccines it pays for now?
So I thought that was a really interesting question when you sent that around the other day, and I did some research, and the Social Security Act requires Medicare to cover those vaccines. So Medicare can't just stop covering those vaccines without an act of Congress, and which I doubt we would see. Part D, Medicare Part D, is required to cover ACIP recommended, and those vaccines that you mentioned are all Medicare Part B. Medicare Part D is required to cover ACIP recommended vaccines, at least according to my research that I did last night. And RFK Jr. could do some things to change ACIP and change the vaccines that ACIP recommends. He could disband ACIP, I believe. And so I think we could see some changes to the vaccines that Medicare Part D covers. That said, I don't think that Medicare and Medicare drug coverage is a priority for this administration. So I doubt that will be something that happens soon, if it happens at all. I also was talking to somebody about this last night who's a vaccine expert, and whether Medicare could just drop its vaccine coverage. And she said that the administration could not do that legally, but they don't necessarily care about what's legal. So I do think that that's, I don't want to be fatalistic about it or, overly dramatic, but it's worth thinking about.
So go ahead, Phil.
No, one thing I was going to say is, they can have big impact on vaccines having nothing to do with covering it or not covering it, because a lot of people just don't get these vaccines. And trying to keep the vaccine rates for these, particularly for adults and for flu, even you would think among seniors who are most at risk for complications for the flu, vaccination rates haven't been on the increase, and there's still a big gap. Part of that has to do with some of the questions on COVID, but there have been questions about a lot of people not getting flu vaccine for decades. So I think, you can have an administration who just takes their foot off the gas in terms of promoting these vaccines would reduce the number of people who get these. Because again, without people pushing these vaccines and without efforts, public health efforts to push these vaccines, people aren't going to get them because that's the case now. I mean, we all know people who opt not to get them and don't even though the flu vaccine has been around for 34 years, still don't believe that these flu vaccines can work and or worry about side effects, even though they've been sort of be seen as extremely rare. So I think that's for people who are worried about impact on child and adult. I think that may be the concern in terms of, public health is a lot of communication and it's a lot of constant communication, and even more so than just the insurance coverage, because the insurance coverage has been there for these things, but people aren't getting the vaccines.
Thanks. And we have one more question from the audience that we haven't addressed. So I'll throw it out to whoever wants to take it. In the new administration, do you think the narrative surrounding hospital consolidation could open up help to hospitals, or could open up to help hospitals provide more streamlined services? Have you heard of the narrative around hospital consolidation?
Certainly. I mean, obviously, hospital consolidation is a big reason for why hospital prices have gone up dramatically over the last couple decades, and that I think that question may come down to the antitrust division within the Justice Department more than the HHS and CMS. And the Biden administration had gotten relatively aggressive in going after and trying to stop hospital consolidation. Whether Trump will do the same, they're sort of seen as very pro-business, and let consumers decide, and let's be transparent, and let healthcare providers do as they say, and let the best facility win. That sort of seems like their way they go. So it remains to be seen whether or not they're going to play a big role with antitrust. But we're going to continue to see consolidation, and that's a huge role with prices. And again, the antitrust division within justice plays a big role with that.
Thanks, Phil. And John, from your perspective, what is the one most important thing for the audience to remember from your remarks today?
The most important thing, I think we've all talked a lot about Medicaid, and I think that is probably the most impactful, policy area that we're going to be dealing with under this administration. And that, of course, affects the beneficiaries on Medicaid, and that's the most important, and it's good to keep the focus there. But the providers also don't want it. There are a couple of policy options out there, lists of policy options out there for budget reconciliation, because they're looking for money, and Medicaid is huge, hundreds of billions of dollars at least that they've proposed that they could cut from that program, and that won't just hurt beneficiaries, that will hurt hospitals, it will hurt all providers, hospitals especially. But I guess to actually try to answer your question, I had to talk about it for a second to actually arrive at an answer. And I think that in this administration, more so than in the past, healthcare is seen as an offset. It's always been seen as an offset, but it's usually seen as an offset to then pay for some other healthcare stuff. I mean, like negotiating drug prices so that you can expand the Part D benefit, that kind of thing. I think it's just kind of an offset now. That would be my takeaway.
Thanks, John. And then Maya, from your perspective, what's the one thing you'd like our audience to remember?
I think John put it really succinctly with healthcare is seen as an offset. I think the other thing that I would add is just that there's there are a lot of directions that things could go, and there are a lot of unknowns. And I think we won't necessarily know know things until they happen. And even then, they could go to the courts, and there could be a long process to figure out how policy actually works. So just be nimble and be prepared for things to change a lot and change quickly, or be prepared for things to not change at all because they won't get around to it. I think that's not a very satisfying answer. And I wish I had something more, better to say, but I think just, be nimble.
And Bill, we'll give you the final thought. What's the one thing you think our audience should remember most about our conversation today?
I think the Republicans have the full power of the White House and both chambers of Congress, and they know this is like all times, they know this is not going to last forever, and they know they have very high ratings from the public that they're expecting things, and I think they're going to move very fast, and they're going to use this opportunity. And yes, I agree with John. Healthcare in many ways is not the priority item like it sort of was back in 2009 and 10 after Obama was elected. That healthcare was the thing, and Congress debated it for months and months, almost over a year before passing the Affordable Care Act. But I think Republicans have power, and they have the things they've thought about doing with Medicaid and Medicare that we talked about are things that they've talked about for doing for years. And they have this opportunity now where they have the power. And Donald Trump is a very powerful president right now, and I think the thing is that they're going to try to use it and to try to change policy. And how much influence the politics has over the policy right now, I think the politics is going to drive the policy, and I think that's what I would sort of take away. Trust them what they say that they're going to do, because they've talked about, hey, they're going to change food, they're going to change Medicaid. All you can do is trust it. Yes, that's what they're going to try, and it's going to be interesting to see what Democrats are going to try to do to have some sway in the upcoming Congress. Because right now, it's as we've seen with the Senate finance vote on RFK. Didn't they just needed to try to change the mind of one doctor who's a big proponent of vaccines, and they were unable to do that. And I guess the question is, just what does that portend for the next several months in the next 2 years?
Well, that brings us to the end of this month's Northern Virginia Health Policy Forum. Thank you, Maya, Bill, and John, for sharing your insider's knowledge with us and giving us a preview of what might be next in healthcare policy. For our audience, if you'd like to get in touch with any of these reporters, like you have a tip or a story or some insight, please reach out to me or any of our team at Applied Policy, and we'd be happy to connect you. And before I close, we just sent a message in the chat with links to subscribe to our monthly newsletter and view our Northern Virginia Health Policy Forum website for more in-depth insights into current and perhaps future health policy. I know some of the audience questions didn't get answered. We'll address these questions directly with the panelists, and we'll put the answers on our Northern Virginia Health Policy Forum website. Thank you for being here, and enjoy the rest of your day.